English. We have a huge audience from all around the world. That's the reason why. So on behalf of the Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for attending our webinars. The audience has reached a peak of more than 100 attendees every week, and the lectures have been excellent. Today our topic is DBS for motor recovery, and Dr. Paulo will present the speakers and panelists. Thank you.
Well, welcome everyone. Well, let's start now. Today's topic certainly interests us all. Stroke is the leading cause of disability worldwide, yet treatment options are very limited. Multiple strategies have been used to enhance recovery, including pharmacological treatment, rehabilitation, cell transplantation, and brain stimulation. In particular, DBS is becoming a valuable tool for clinics in the recovery from after stroke patients' disabilities. Translational medicine, DBS for motor recovery after stroke, from the laboratory to the patients. Seems to be answers, or perhaps the right questions happen in translational medicine. Okay. Today's guests, today we have a selected and important group formed by professors and heads of medical residence programs. Professor Alexandre Francisco is a neurosurgeon, head of Neurosurgery Department at Hospital Universitário Cajuru, Curitiba, Brazil. Professor Kleber Duarte is a neurosurgeon, Hospital das Clínicas, Universidade de São Paulo, Brazil. And Professor Maurício Siqueira is a neurosurgeon, chair of the Neurosurgery Residence Program at Felício Roxo Hospital in Belo Horizonte, Brazil. Professor André Machado received his medical degree, is our speaker. Professor Machado received his medical degree from the University of São Paulo and completed his residency and obtained his PhD in the same institution. In the Cleveland Clinic, completed his fellowship in the stereotactic and functional neurosurgery and has been on the staff of the Cleveland Clinic since then. His research in deep brain stimulation was awarded the National Institutes of Health Directors New Innovations Award and Gildenberg Award of American Association of Neurological Surgeons. Actually, Professor Machado is director of Center for Neurological Restoration and chairman of Cleveland Clinic Neurological Institute, USA. Professor Machado, the stage is yours.
Thank you, Paulo. Thank you for the organization, Brazilian Society, for inviting me for this presentation. It's a pleasure to be back with my colleagues and friends from Brazil. I will try to share my screen now and follow the instructions here. The objective of my presentation today is to really discuss the project that we have worked on for now almost 12 years, evaluating the possibility of the use of deep brain stimulation to promote rehabilitation after stroke. Deep brain stimulation is a standard treatment for Parkinson's disease, essential tremor. It is considered also a standard for patients with obsessive compulsive disorder that is refractory to medical management and for some forms of dystonia. In all of those treatments, we are attempting to use DBS to take away a symptom, to take away a so-called positive symptom, a tremor, rigidity, obsessions, a dystonic movement. What we are attempting to do here is quite different. In fact, almost the opposite. We are attempting to make a function come back following paralysis. The objective of deep brain stimulation as we are studying it is not to prevent the secondary injury of stroke or to reduce the infarct size. It's not an acute treatment that we're proposing. What we are proposing in this research and the data that I will present to you in a moment is the use of deep brain stimulation to help with the rehabilitation in the late phases. Patients are being enrolled a year, 2 years, 3 years after a stroke, to learn if we can pair deep brain stimulation with physical therapy, with rehabilitation therapy, and augment, that is, to boost the effects of physical therapy by means of neuromodulation. These are my disclosures. In case there are CME relations to this presentation. And as Paulo was talking about a moment ago, stroke is the leading cause of disability in the industrialized world and in the developing world, in the industrializing world, Brazil. It is also becoming a leading cause of disability as infectious diseases become less common and cardiovascular and cerebrovascular disease increases with the aging of the population. Brazil will very soon show a pattern of stroke epidemics similar to industrialized nations. In the United States statistics alone, there are approximately 500,000 strokes and survivors per year. 50% of them present with long-term deficits that are severe enough that they need the help of another person to perform activities of daily living. That is the threshold that we consider for severity. They can no longer live independently. The rehabilitation strategies that we have today are the same as we had 20, 30, 50 years ago. Physical therapy, occupational therapy, speech therapy, essentially repetition to try to have the patient recover from the deficits. There is an ample opportunity to utilize new technologies to help patients recover beyond what physical therapy alone can do. This is not a novel idea. There are thousands of studies in the literature attempting to evaluate the effects of brain stimulation on motor recovery. The most common ones are with non-invasive stimulation. That's like transcranial magnetic stimulation or transcranial direct current stimulation. Studies done worldwide, including several studies from Brazil. To date, transcranial magnetic stimulation is really a research tool. It's a tool that allows us to investigate the mechanisms of post-stroke rehabilitation. But repetitive TMS has not yet been shown to be consistently effective for post-stroke rehabilitation. What about epidural stimulation? This was a very promising approach some time ago. There was a large pivotal study in the United States with dozens of hospitals participating, in which the area around the stroke was stimulated with an epidural electrode, with an epidural grid. Even though the early phase results were promising, the final results did not show any benefit. What about deep brain stimulation? We think we have a new opportunity here. We think that we have an opportunity to utilize the natural pathways of the brain to deliver the effects of the stimulation as it's ascending from our target of choice, which is the deep cerebellar nucleus, via the thalamus to the cortex. I am going to show a quick animation here that I hope will work to explain what is the pathway that we're targeting. So the electrodes we're implanting, I'll go back, the electrodes we're implanting are in the dentate nucleus of the cerebellum, and the objective is to stimulate through the thalamus, which is an excitatory synapse, always excitatory, to the cortex, anterior part of the cortex, coronal cortex, parietal cortex, where the projections really spread to the effects of stimulation. And by stimulating this disynaptic excitatory pathway, we want to increase perilesional excitability, facilitate motor function, and improve outcomes associated with physical therapy. My objectives today are to present how we transitioned from rodent research, laboratory research that we began 10, 12 years ago, towards proof of principle, and then into the human brain for the first time. So my objective is not only to talk about stroke rehabilitation. My objective today is also to talk about how research can be initiated in a laboratory and then brought to the bedside, brought to patient care by a group that is led by a clinician, by a neurosurgeon. And I think this is one of the great opportunities of functional neurosurgery as we move ahead, is to bridge our knowledge across species. And I think functional neurosurgeons are really well positioned for this kind of work. Let me show you the very first experiment that we conducted in the rodents. This is an animal that had suffered a middle cerebral artery stroke caused by us. And then we implanted an electrode in the dentate nucleus and a microelectrode in the motor cortex. The electrode in the motor cortex is only stimulating to cause a twitch on the opposite paw, whereas the electrode in the dentate nucleus is being turned on for a period of time and then off, on for a period of time and then off. And what we want to see is if the stimulation in the cerebellum can increase the amplitude of the motor evoked potential, which is a demonstration of increased excitability. So this is raw, unprocessed data as it's coming out of the electromyography. And you see here on my arrow, can you see my arrow? Do I need to use the pointer? Can you see my arrow?
Yes, we are seeing.
Here on my arrow, on the left side of the graph, the stimulation is off, on, off, on, off, on, off, on, off, on. Highly reproducible effect, showing that in these animals we could actually promote excitability of the cortex around the stroke with stimulation in the dentate nucleus. Then we did a frequency response curve to find out the optimal frequency for stimulation. When we stimulate patients with Parkinson's disease, we're trying to make the tremor go away. We are typically using high frequency, 130, 150, 200 hertz. In this model, we learned that 30 hertz, 30 pulses per second, was really the optimal frequency for stimulation. We then went into a chronic model to see if we could chronically implant DBS in the rodents after a stroke and see if we could actually make them recover from the stroke. Does it work? What you see on the left side of the graph are the two groups of animals. As they were being trained, they could achieve a score of 35 in the scale that we use to measure function in the lab. They are still normal animals until this dotted line happened. In this day, we gave them a middle cerebral artery stroke, and they dropped function. And then they were randomized to either have the DBS on or off. They are all implanted with the same electrodes. And then you flip the coin, half of them get the DBS turned on, half of them remain with the DBS off. And over this span of 5 weeks, you see a separation between the two groups. The group in red receiving DBS, the group in blue, sham. The electrode is implanted, but the electricity was never turned on. And this has been reproduced in our lab several times and has been now reproduced also at Stanford University with optogenetics. They implanted in the same way we did, utilized a different kind of stimulation, and were able to validate and reproduce our results independently. We then went on to study the mechanisms, what's happening to the brain of the rat when the animal is getting better. So we mapped the cerebral cortex. You can see here the grid of mapping. In each of these dots, we inserted a microelectrode and we stimulated. This is the normal, naive animal before stroke. In yellow, you see the representation of the primary motor cortex. That's how it is in the rat. One over here, where my arrow is, you see sham, meaning the animal has suffered a stroke, but has not been treated with DBS. The yellow area has essentially gone away. Then we tried 2 types of stimulation, and you see a resurgence of yellow and red, or red, and they represent the affected forepaw. So as the animal is recovering function, the representation of the affected limb is coming back to the cortex, indicating to us that reorganization of the cortex is one of the mechanisms related to the recovery of motor function. We then conducted a series of experiments with Western blots. And to do this, what we did was to obtain a biopsy from adjacent to the lesion, shown here in this red circle, the opposite side as a control, and the visual cortex as another control. I'll draw your attention to this column here. In gray, you see the sham animal. That is the animal that suffered a stroke but did not receive any treatment. In green is the naive, the normal animal that never received a stroke. And in blue and red, the 2 types of stimulation that we're trying. You see that there is a substantial increment in the expression of NMDA receptors, calmodulin receptors, and important, in my arrow here, synaptophysin. Synaptophysin is a protein that is present only in the synaptic vesicles at the dendritic terminal. If this protein goes up, as you see that it went up with 2 types of stimulation, that's an indication that there are more synaptic vesicles after treatment than before, suggesting formation of new synapses. We then conducted 3-dimensional electron microscopy to find out if these synapses were fully formed or if they were defective synapses. And we were able to see in the morphology of the synapse that it's fully formed. You can see in blue the presynaptic terminal, in yellow the nucleus on the other side, the postsynaptic terminal, and in black is the postsynaptic density, which is really the microscopic indication that these synapses are fully formed. When we counted the synapses one by one, we learned that the animals receiving treatment in blue or red had double the number of synapses than the sham animals that were randomized to no stimulation. So in summary, what we had learned in the animal model is that deep brain stimulation could enhance the excitability of the perilesional cortex, could enhance the recovery of function of the affected limb after a stroke, and did so by means of driving plasticity at the system level, meaning the reorganization of the cortex, as well as at the cellular level with a higher number of synapses. Based on this, we took this data to the Food and Drug Administration, the FDA, as well as to the National Institutes of Health, the NIH. It's the American equivalent of CNPq, right? The National Funding Agency, to obtain funding and regulatory approval by the ethics committees to be able to translate this research from laboratory animal research to a first-in-man clinical trial. This has not been tried yet. And this is how the electrodes look and their position in the small brain of the rodent. And now you see our surgical strategy via the posterior fossa through a borehole in the suboccipital area to penetrate the dentate nucleus. Patients that are being enrolled in this study, it's called EDEN study, have moderate to severe hemiparesis. They can sometimes not move the hand, sometimes move it a little bit. They are between 1 year and 3 years after a stroke, and they have suffered a unilateral middle cerebral artery stroke. I'll ask you to come back to remember this picture that I presented to you a moment ago on the rodent model. You remember that I showed you the stimulation off, on, off, on. We have been now able to reproduce this in the human. Of course, we did not place a microelectrode in multiple parts of the cortex. We asked Dr. Ila Plau, one of our collaborators, to map the patient's brain with transcranial magnetic stimulation. So she's mapping the brain, finding the hot spot, and then she uses pulses of TMS to cause the motor response on the affected extremity. And we then turn the DBS on, and during the period in which DBS is on, she tries it again, and then we test it again after 1 hour once the system has been turned off to evaluate the carryover effect. And just like in the rodents, we were able to observe, if you see here the left bottom part of the screen, we're able to observe a significant increment in the magnitude of the motor response with the DBS on, but we did not see that when the DBS was off with sham. Likewise, the motor threshold improved when DBS was on, but did not change when DBS is off. This gives us an early assessment that the translation is true, that what you see in the animals actually can be reproducible in humans. What about long-term outcomes? We're in the middle of it. We are recruiting 12 patients. The 11th surgery is tomorrow morning, and we have so far outcomes in 7. The design of this study has essentially 2 layers. The bottom layer is rehabilitation. Patients start the study with physical therapy. They have physical therapy throughout the study, and they finish the study with physical therapy. Then, during a period of 4 months, physical therapy overlaps with stimulation. And what we want to learn is if the outcome at the end of physical therapy is superior to the outcome before physical therapy. These are the results of 7 patients. Out of 7 patients, 4 patients have reached the threshold for response. That is an improvement of 5 points or more in the Fogel-Meyer upper extremity scale. We have 3 additional patients that showed some improvement, but 2 of them, didn't quite make the threshold that we had set. This is considered a clinically significant effect, and it is the objective that has been attempted with non-invasive stimulation, but without the expected benefits. And it was also the objective of epidural cortical stimulation, even though the pivotal trial could not achieve it. In our early study, we are learning that a proportion of our patients already demonstrate the benefits that we have been hoping for. I'll give you one example. This is a lady called Judy. Judy is our first patient. We have authorization to use her image. And what you are seeing in this image here is that she's throwing the first pitch of a baseball game in Cleveland. What matters in this image is not only that she can hold the ball, that's relatively easy. What matters here is that she can open her hand and let it go. It's that extension on command that she gained during rehabilitation. And the ability to extend the fingers is really what is a challenge in rehabilitation after a stroke, especially 3 years after a stroke, like when we enrolled Judy for this study. It's that moment of releasing the ball that really caught our attention. I'll take a quick detour here to talk about closed-loop DBS. Everyone is seeing presentations in Parkinson's disease, closed-loop systems. You can record the activity from the subthalamic nucleus, and based on that activity, you can decide if the stimulation is going to be delivered or not. Is there a possibility for that in stroke? We think that there is. I'll skip a little quicker through the data, starting again with animal data, and then I'll show you human data. This is a series of 5 microelectrodes implanted in the dentate nucleus of the animal. And this is the animal going through a reaching task. The animal has to cross a beam of laser beam, and then after crossing the beam, they reach, grab a sugar pellet, and bring it to the mouth. And they are being recorded with video. Then we see in the video if the reaching task was successful, meaning did they grab the sugar pellet or did they drop the sugar pellet? If they grab the sugar pellet and bring it to the mouth, that's successful. If they try to grab it but they drop it, that's unsuccessful. And this is the activity from the dentate nucleus of the animal. Hits, meaning success, misses, failures. 0 in the dotted line represents the moment when they broke that beam break, right before grabbing the sugar pellet. I ask you to take a look at this. What do you see as the difference between failure and success? There is a lot more activity in the failures. The cerebellum is firing a lot when the animal is failing, trying to correct the movement. Doesn't fire as much when things are just going fine. And even more interesting, did you guys notice that the cerebellum is firing a lot even before the beam break happens? The cerebellum knows, even before the movement is finished, the cerebellum already knows that the motor plan is bad and tries to make corrections in real time. When there is a hit, that doesn't happen. We hope to be able to capitalize on this and to stimulate at the time when a miss is expected, to alter the course of the event that is going to happen, not the event that has already happened, or to influence the motor learning over time so that the animal can rehabilitate better. We're not doing that yet. The stimulation so far is monotonous. It's always on, like our Parkinson's patients. We think that this type of signal will open an opportunity for closed-loop stimulation. Does it happen in humans? Yes, it does. So this is one of our patients. I think this one is the 5th patient. Having a task. Instead of grabbing a sugar pellet, we give our patients a video game. The video game is pretty simple. They get this arrow, and they have a dynamometer. They have to squeeze really hard when they see the arrow, and then they have to let go. So when the arrow comes up, squeeze, let go. And they have to open the hand and drop the ball. And we do EEG. We also record from the dentate. And this is activity from electroencephalography, from EEG. We tried 2 different settings. Setting number 1, setting number 2. The contacts, the polarity is different. Setting number 1, DBS off, DBS on. Didn't see much. Setting number 2, DBS on, significant modulation in the beta band. DBS off, excuse me, significant modulation of the beta band during the task. DBS on, modulation went away. No modulation in the beta band. So there is an effect on motor cortex motor planning comparing DBS off to DBS on. The patient was turned on to setting number 2. And sure enough, this is one of our responders. We think this is going to be one of our programming biomarkers to help us guide how to adjust the stimulation when we're programming the DBS in clinic. To summarize, before I thank the society and open for discussion, we are in the middle of this research still. I have one more surgery tomorrow. We are learning as we go. New interventions are very much in need for patients with stroke rehabilitation. For patients with stroke, we need to help recover beyond what physical therapy alone can do. DBS of the dentate nucleus has so far been well tolerated. I showed you the data in 7 patients that have completed the study. We have already implanted 10 patients. 3 patients are currently undergoing the study. And so far, the surgery is well tolerated. Knock on wood. The early data in humans seem to match quite well the data from our rodent laboratory. The translation seems to be effective. And we have found meaningful improvements in 4 out of 7 patients. Of course, this is a phase 1 study, single center, not a controlled study, open label, but we're encouraged by the early results. I think everyone here understands that I have the privilege of presenting this data to you, but this is the work of a very large group of people. I could only put the name of some of them on the slides, but I really want to acknowledge a few people here. Sean Nagel is my partner in functional neurosurgery. He has helped me do some of these surgeries. And Ken Baker is my partner in the laboratory, really a remarkable scientist that I have the privilege of working with. I want to thank the Brazilian Society for the opportunity and join the moderators for discussion.
Okay, we are so proud about your work. Dr. André.
Well, congratulations, Professor Machado. It was very elegant. Beyond learning about new DBS technique, we remember the importance of the function and of the cerebral and the movement. And I think maybe we learn more about the importance about the translational medicine, the science. Wow. Now, I would like to invite our moderators to comments and questions. First of all, our first moderator, Professor Alexandre Francisco. Professor Francisco.
Hi, Paulo, can you hear me? I think that my connection is
yes.
a little unstable, so please let me know Andre, if you can't hear me, just please let me know.
It's fine.
Thank you very much for your presentation. Brilliant as usual, as Paulo said. So I'll start with my questions, and there are so many questions about this that we can spend like asking questions, but some of them really come into my mind, and I think they are particularly interesting, and I would love to know your insights. So basically, I have two questions, and they are kind of related. I'll make the first one, and then I'll follow to the second. I don't know your stimulation parameters. I don't know if you even can discuss about that, but I saw that in some aspects you were using like 30 hertz, if I'm not wrong. Some of the studies were done with 30 hertz. And we do understand that whenever we use low frequency stimulation, we think that we're going to do, we're going to stimulate, we're going to drive the function of a neuron. And if we do a high frequency stimulation, we are inhibiting that neuron. This is very simple. This is very common sense. But let me see if I can make this clear. If you use, for example, 30 hertz, you're stimulating something, you are driving stimulation. But if you think that the dentate nucleus may have, and you can see some evidence of how can I say, high activity at the dentate nucleus, wouldn't it be reasonable to try high frequency stimulation if you use the closed loop? So for example, you can foresee that the dentate nucleus is going to respond in a very different way that can make the movement more difficult to the patient. So do you think that high frequency stimulation in this sense could be an option? Yeah. I don't know if I make myself clear, but.
You do. I think what Professor Francisco is saying is that we are using 30 hertz stimulation because that's what we learned worked in the animals. And it is what worked in the animals. Mm-hmm. And we think it's working in humans. But the stimulation is going continuously. If we move from this paradigm to on-demand or closed-loop stimulation, should we use low-frequency stimulation or should we consider high-frequency?
Yes.
For brief bursts. I think you're completely correct. It may be that bursts will work well. The physiology of the cerebellum may also may, however, suggest that the stimulation at 30 hertz will be better even then. And here's why. We didn't do this work. This is work from the 1960s. If you want to go read it, the author is Tact, T-H-A-C-T, Missouri. I can pull the papers for you. He investigated chronic recordings of the dentate in non-human primates, normal animals, not with stroke. The frequency of activity of the dentate is actually a little higher, like gamma, 50, 60. When the movement starts, it drops to 30. So 30 hertz is actually the frequency with which the dentate, the thalamus, the cortex, and the muscle synchronize at the moment of movement onset. So my current thinking is that if we get to closed loop, that we should use periods of 30 hertz at the beginning of motor planning to facilitate that synchronization. But to your point, we don't know that. It's what we think. We'll have to compare 30, 50, 100, 200, because maybe the burst works better. But if you want to try to mimic nature, the attempt to mimic nature would guide you to use low frequency.
My second question is even more hypothetical, but I think this is interesting to play on this ground. So you probably are aware about papers and the research that has been done by the group in Louisville and spinal cord stimulation for quadriplegic patients. And yes, when you read those papers, Yes. So when you read those papers, they have a very interesting insight about it. And they really consider that you shouldn't keep the stimulation on all the time. So they say that it's not that you are regrowing neurons, that you are promoting regeneration of neurons. Is that there are some pathways that are still viable anatomically at the spinal cord, and that these pathways may be dormant because of the lesion. So once you turn the stimulator on, you may activate these fibers. So that's the logic of the procedure. But there's something even more interesting. They say that you should turn on the stimulation when the patient is doing physiotherapy, not if he is, for example, in a resting state, but when he's doing physiotherapy. And more interestingly, they say that the patient should participate consciously on the movement, that he needs to think about the movement that he's doing. Otherwise, the effects are not the same. So this is our very, preliminary studies with preliminary results, but these insights are very interesting. So do you think, or do you consider that maybe to stimulate when the patient is consciously thinking about the movement because of these effect that you may see before, that this may be an issue to your research? Do you think that this is a viable thought, or am I just losing my mind?
No, you are perfectly on target. We had several debates when we were discussing the design of this study. And we have two really stellar rehabilitation physicians guiding this study. You guys should look them up. One is John Shea. He's from the Cleveland Metro Hospital. They're experts in rehabilitation. And the other one is Steve Wolf. And if you go look into the stroke literature, there is a scale for stroke recovery called the Wolf scale. That's him. So he's helping us decide this. And this was the debate around how to do the cycle of stimulation. Do you leave it on, or do you turn it on? Do you let the physical therapist turn it on before the patient starts a session, right? And the decision to leave it on was based on two things. Number one, when they did epidural stimulation, that was called the Everest trial. It's published in Stroke, if you want to look it up. Robert Levy is one of the lead authors. They only turned it on during physiotherapy, and it did not work. So that made us think, well, it didn't work in that study. Should we do the same thing, or should we try something different, right? And the second one is that the patients come for physical therapy 3 times a week. And they have homework to do. The physical therapists tell them to try to use the affected extremity at home. Try to use it when cooking. Try to use it when washing. Try to use it to grab soap and wash yourself. Try to use to grab your phone. And we thought that those were equally important rehabilitation opportunities in the patient's own environment as the physical therapy with the physical therapist is important as well. So we thought that sending them home without stimulation and telling them to use the limb was not going to be as effective if stimulation would be off as if stimulation is on, even when they are trying to use the limb at home. So those were the two decisions, but it was very controversial. We still don't know what's best, right? We never tried it the other way.
And just one final question, quick one. How did you come up with the dentate nucleus? Why the dentate nucleus?
Sure. When I was studying possible pathways, my first inclination was to stimulate the thalamus. It's direct. There is only one synapse to the cortex. And you know you're going to stimulate the cortex. You are one synapse away from it. The problem with thalamic stimulation is that you need to pick one nucleus. VIM, for example, goes almost only to the primary motor cortex, M1. And in these patients, there is no M1 left. Most of them don't have M1. So you're stimulating cerebrospinal fluid, right? Stimulating that brain. You can then put it in the mediodorsal nucleus. Mediodorsal nucleus projects predominantly to prefrontal cortex. But then you're not getting whatever is left over of M1. You're not getting parietal, the area behind the stroke. You can put it in VOA, and then you get the opposite. So the idea of the dentate came because it projects to 5 thalamic nuclei. And through those 5 thalamic nuclei, you extend the fibers to a broader array of cortex. So I was looking for a node in the brain that would be amenable to a single DBS electrode, where I could get a robust spread of activity through the cortex. Could it work if we did thalamic stimulation? Maybe, but it's not what we went with for this reason. You would have to implant several thalamic electrodes to be able to cover as much real estate, right? As much area of the thalamus as we're currently getting with dentate stimulation.
Thank you. Thank you very much, Andre.
Dr. Machado, just one question. How are you?
Yes, please, Professor Duarte.
Oh, okay. Just one consideration. We have a clinical trial of DBS in dentate nucleus for one clinical neurological untraceable disease. There is ataxia. We have patients with genetic ataxias, and we promote from the laboratory then to surgical room, and we have MER register of the dentate nucleus, and the difference of the intensity, the frequency, and the amplitude of these spikes is a large from more affected side from to the other. Are you reading the both sides, the two dentate nucleus, or just affected side?
Affected.
Affected.
We are not doing both sides yet. We did it unilaterally in the rodents, and we're doing this on one side opposite to the stroke. So left side stroke, right side nucleus.
Yes. The intercortical synapse, leaving the more inhibition intercortical.
So Professor Duarte was asking a question and making a comment. His comment is that the dentate nucleus has a lot more afferents, a lot more input than output. Completely true. It's modulated by essentially 2 types of neurons. The majority of the modulation comes from Purkinje cell fibers that come from the entire cerebellar surface. Huge modulation, that's inhibitory modulation. And then it has excitatory modulation from mossy climbing fibers that come from the olivary nucleus, from the brainstem. And those inputs far exceed the number of neurons coming out. When you stimulate with an electrode, you override most of the inputs. The amount of exogenous electricity going in will really overcome the presynaptic inputs, and you're driving the postsynaptic outputs. Now, the question from Professor Duarte is, do I put the electrode in the dentate itself, or am I putting it in the white matter coming out of the dentate? The first 3 patients, we placed electrodes. They are Boston Scientific electrodes with 8 contacts. They're long electrodes, octopolar. We placed 3 electrodes going up to the superior cerebellar peduncle. Just like you said.
Like us.
Just like you said. Just like you said, Kleber. You got it. Stimulating the white matter to make it more efficient. and the other 5 electrodes were inside the gray matter, inside the dentate. And what I wanted to do was to activate the white matter, catch all those fibers going up to the thalamus. And the white matter is what we stimulate in the animals.
Okay.
So, but here's the problem. When we turned it on at like 0.2 milliamperes, the patient throws up. It's highly repetitive. At one point, she told us to stop because it was like turning on a vomiting switch. You click the button of the programmer, she throws up. You turn it off, she stops. I'm like, well, let me try again. You push it again. She's like, I'm nauseated, I'm not feeling well, throws up. Then you turn it off, she stops. And then she's a very nice lady, the small town in Ohio. So, hey, doctor, can you stop pushing the button? And we never pushed it again. So as soon as you go out of the white matter and you go into the gray matter, that effect goes away.
Yeah.
I think that we're stimulating area postrema. It's too close. So now we don't put the electrodes in the output anymore. Now we stimulate only the gray matter, only inside the dentate. The side effect was brutal. I mean, the patient was highly symptomatic for a few seconds. No dizziness, no vestibular effect, no nystagmus, pure nausea.
Great, great, great. Professor Siqueira, Professor Mauricio Siqueira.
Yes. First of all, I would like to congratulate Dr. Machado for his elegant presentation. Very nice laboratory work. But I have some questions related to what Dr. Novick has asked before. I had the opportunity to see many presentations in the 70s, in the 80s, in the 90s, of the group of St. Barnabas Hospital in New York. And they stimulated several structures, cerebellum, thalamus, internal capsule, and spinal cord. And they had results similar of yours. I would like to ask you if you think that the target doesn't matter. You have to have one afferent via, one road to stimulate. You can stimulate the internal capsule, thalamus, cerebellum. And my question, what's the difference of your technique from the technique from St. Barnabas Hospital?
Technique of which hospital?
What's the difference? They used in the 7th and in the 8th the cerebellar stimulation, and we are using 40 years later with the same results.
Yeah. So the stimulation that was done at New York University by Irving Cooper was not the dentate nucleus. He was stimulating the surface of the cerebellum. So the approach was supracerebellar infratentorial. He placed flat quadripolar electrodes right lateral to the vermis in the paramedian cerebellar area, right below the tentorium. And the objective there was really to evaluate the effects on epilepsy and spasticity in patients with cerebral palsy. The work was done for a period of time, and then they abandoned it. And they abandoned it predominantly for spasticity. I don't think it was quite as effective. And they continued, I think, for a longer period of time on epilepsy because it was more promising. And I think eventually it was given up because better ways of treating epilepsy came up. I think that the difference here is that they were stimulating inhibitory neurons. They were stimulating the Purkinje cell fibers. So effectively, they were inhibiting the dentate nucleus. And what we're trying to do is the opposite. We're trying to drive the output of the dentate nucleus. If my objective was to modulate spasticity, I think that the approach that Dr. Cooper attempted in the 70s would be very good to revisit with modern implants, better technology. Because by inhibiting the dentate nucleus, if you can achieve, for example, the equivalent of cerebellar hypotonia, it may work for spasticity. And the idea would be corroborated by work done in the US and in Europe with dentatotomies, ablation of the dentate nucleus for spasticity. We do have a colleague in Brazil, Professor Manuel Teixeira. When he trained under Hitchcock, they did this. And I think it was effective. I think it worked well. But once baclofen became available and the DRES and the Dundee-Mackenzie surgeries became more prevalent, people began to prefer to do selective ablation of the dorsal roots or intrathecal infusion of baclofen versus ablation of the dentate for the treatment of spasticity. I think if we wanted to use the target for spasticity, I would do exactly what Dr. Sequeira is saying.
One thing more. In that time, they presented results for hemiparesis, cortical paralysis, for movement disorders, for pain, and the results, they were almost the same as yours, almost 60% of improvement, 50%. My question is the target the most important, or the parameters of stimulation, or the road of afferent stimulation? You can use peripheral stimulation, vagus nerve stimulation. If there is a difference, or you can use one road of afferent stimulation, and the result will be the same.
Sure, that's quite possible. I mean, when we treat patients with Parkinson's disease, we put the electrode in the subthalamic nucleus, in the pallidum, and in the thalamus. And well, the tremor gets better. 3 different nodes, same loop. But I think that there is a lot of truth to what you're saying. Could we put it in the olivary nucleus, for example, and get similar result, perhaps? Could we put it in the thalamus and get a similar result? Perhaps. I think we need to go do it and see what happens.
Okay, thank you very much.
Makes sense, yeah. I understood your question the second time. It makes a lot of sense.
Great. I would like to invite now our special invited, Professor Leonardo Frison. Your microphone. Open your microphone, please. You open and close after that.
Too much technology.
Leonardo?
Leonardo, there you go.
My internet is unstable here. Okay. Thank you. Okay. Thank you, Dr. Paulo. Thank you for the invitation. This is a privilege to listen to this brilliant presentation and also make comments and questions. Actually, my questions were already addressed. And well, I am a witness of the efforts and how seriously Andre and his team have conducted this work in Cleveland. And this is amazing to start to see the results. And Andre laboratory to the first clinical trial in humans inspires me, and I believe many others neurosurgeons to at least try with our tools to make some real translational science. I wanted to congratulate you and thank you for your presentation. And all my questions were addressed. As I said, I like your insights and why you did not choose to start stimulating the thalamus. Why did you choose the dentate nucleus? And I will pass. I see that there are some other questions for the audience. I have no question.
It was a pleasure to have you here for 2 years.
Thank you.
Great, great. We would like to invite our president, Professor Antonio Almeida, and after that, we have some questions from audience. And Professor Antonio Almeida?
Actually, Andre, it was a great presentation. I think translational medicine is science. It has to be done. And you've been doing this for more than 20 years. I remember well your doctorate, your thesis about the lesion of the half of this one of the cerebellar hemispheres was very interesting paper. Actually, the question, I think the most important question, I think everybody had the same, was about the choice of the dentate nucleus, but you gave a very good reason to do it. Another question, do you have any special electrode, or you said you put just the whatever DBS electrode, the regular one, is it?
Yeah, we tried 2 different electrodes so far in humans, right?
Yeah.
One is the directional lead, and the other one is the non-directional lead. Ken Baker and I thought that the directional lead was going to be very important. We thought that we would be able to study not only in and out of the cerebellum, but also up and down, right and left. And after doing it, we have learned that the directional lead makes absolutely no difference in the dentate. We dropped it, and now we are using only non-directional leads. It doesn't help. The dentate is quite large, and directionality is lost after 1.5, 2 million years. So we're using very standard common electrodes.
Very interesting. So Paulo, it's your time.
Great, great. We have some questions from the audience. I resume 3 questions in. They ask you, Professor Machado, they would like to hear comments about optogenetics and the dentated nucleus stimulation.
Yeah, so the idea, we never did it. Other groups have now done optogenetics using the same model, and the results were the same. So you stimulate with electricity, you stimulate with light, the result is the same, you're stimulating the nucleus. The advantage of optogenetics is to understanding which pathways you're working on and to isolate pathways. And I'll try to quote from memory. I think the result of the work was that the effect was really glutamatergic more than anything else. It was almost an exclusively glutamatergic efferent effect rather than other local networks involved.
Great. The other questions is about the use of functional MRI or TMS to maybe better predict which patient will benefit from DBS of dentated nucleus.
Yes. As you saw, we have a collaborator that's a transcranial magnetic TMS person, Dr. Plow. We have about 25 papers published with her, and she participates in the study. The idea is exactly what you're suggesting. Can you predict the outcome with TMS before you put in the DBS? With a sample size of 7, we don't know. We can't tease it apart. We can't tell if TMS was predictive or not. As we begin to expand the sample size, maybe TMS, maybe fMRI, we're also collecting PET, positron emission tomography. Maybe those will be indicators of which patients are likely to respond which patients not likely to respond. I will tell you which one I think will be the best without knowing the results. We need a few more samples to be able to separate the patients. I think that DTI, tractography, will be an important predictor of outcome. I think that having some degree of integrity of the pathways after stroke will be the best predictor of outcome. But to be transparent with the audience, I don't know that. We do not have enough volume to be able to analyze the data in a way that would tell us whether TMS or MRI or PET, which one can be a better predictor. Too early to tell.
Great. The other questions is the same line, but they ask about the most important clinical features could have to predict the better response. I believe you answered with the same answer. I believe it's not yet possible.
Too early to tell.
The clinical features.
Yeah, the one clinical feature that we have noted is that severe spasticity is not good for recovery, and the DBS doesn't fix it. The patient, after 3 years, they already have passive rigidity, contractures of the tendons, loss of muscle, and even if there is neuromodulation, the hand is too damaged to participate in recovery. So I believe that patients a little earlier in the journey in stroke, not as chronic, will be better responders, and patients with less stiffness and hand damage will be better responders.
Well, the other question is how dentated nucleus stimulation could reverse the effects of crossed cerebellar diasthesis, stroke recovery.
Very good. The hypothesis here, when we developed the hypothesis, and I will direct you for a paper written by Ken Baker and I think in 2010. It's published in Frontiers of Neuroscience. The name of the paper is Upside Down Cross-Cerebellar Diasthesis, because we were proposing that by reversing cross-cerebellar diasthesis, that was a hypothesis, that was one of the possible mechanisms for the effects that we're learning now. The choice of the cerebello-thalamocortical pathway as an opportunity for long-term stimulation in patients with stroke was guided by cross-cerebellar diasthesis. And if you are interested in reading that paper in Frontiers, you will see our thought process around cross-cerebellar diasthesis. One of the interesting things is that patients that have a stroke and evidence of cross-cerebellar diasthesis have worse rehabilitation outcomes after a stroke. This is work that came out of Japan about 10 years ago. So if you reverse cross-cerebellar diasthesis, it is possible that the patients will have a better outcome.
Great. Another question, the last one, and then I back to the moderators if they have any comments or question before we finish. The question is, you showed better desynchronization during on-condition EEG study. Is there any on-drive power enhancement? If it's so, in which EEG band?
Power enhancement, we don't know. What we evaluated primarily was during a task, which areas of the cortex, and we also recorded from the dentate, which areas of the cortex were being modulated or desynchronized at the moment of movement onset and offset. And we found that DBS was more effective at modulating right in the area immediately adjacent to the stroke. For example, FZ in a patient that has a relatively small stroke showed very high modulation before DBS and showed a reduction in modulation when DBS was turned on, or a change in modulation when DBS was turned on. I wouldn't be able to tell you if the power, meaning if recruitment at rest was effectively modulated. I think we don't know that yet.
Great. I'd like to back to the moderators. Is Professor Antonio Almeida, please.
Now, just a simple question. How long takes on average in your patients from the stroke to the surgery?
The patients were typically recruited at 2 years.
After 2 years. Do you think earlier recruitment would produce better results?
Yes.
Simple questions, simple answer.
Professor Novick, Francisco.
Microphone is off, Alexandre.
Sorry, Andre. Andre, two simple questions. One of them, you seen, for example, the video that you showed from the first lady that was implanted, and there was some very impressive images. Do you see any lasting effects even when DBS is off for these patients? Did you check that or not yet?
We did. So part of the study, if you, let me see if I can share my screen again. Can you guys see my screen again?
Not yet?
Not yet.
For you. How do I get the... What about now?
Yes.
Yes? So can you see this slide here that shows...
I'm just seeing that you're doing propaganda for Windows right now. I just see the Windows logo on the screen.
Can you see now?
Yes.
So this is the design of the study, Alexandre. And if you notice here, the stimulation turns off and the physical therapy continues. Because we wanted to know if there were carryover effects of stimulation. If you turn off the DBS and the patient continues with physical therapy, do they lose the improvements that they had? They do not lose the effects. So unlike Parkinson's disease or essential tremor, you turn off the electrode, the problem comes back. In chronic neuroplasticity that we're inducing here, if they improve and you turn off the stimulation, as long as they are still using the hand and doing physical therapy, the gains are maintained. So this we actually know. We formally evaluated it and we know the answer.
Do you think this may be a proof of concept? Of course, it's not that it doesn't go that long, but a proof of concept that some neurogenesis exists, or only that you're only driving some different circuits on the brain. What's your opinion about it?
Yeah, in the rodents, we saw some neurogenesis. It is published, I think, 3 years ago in Neurosurgery as a basic science paper. We found some neurogenesis coming from the periventricular areas. I would say that the effect on neurogenesis is small compared to the network effect and to the effect on synapses. I think the likelihood that we're promoting synaptogenesis as a meaningful mechanism is greater than the effect of neurogenesis as a mechanism of recovery. Did I answer you okay?
Absolutely. Thank you.
We have one question more from audience. Is about, it's very simple question, very direct question. It's about parameters of stimulation: monopolar, multiple, monopolar, bipolar, and amplitude. How is the best and the worst parameters to stimulation, Professor Machado?
We are learning that, and programming these patients has been the hardest part of the study. It's such a complicated part of the study that I didn't present because it takes an hour. Leonardo was here when we were doing this. I have a full-time electrical engineer looking at programming data and electrophysiological data. This is a very capable person. And 2 more full-time researchers just looking at activity during programming to try to understand how to best program. We tested predominantly low frequency. Pulse width is still a matter of debate. We don't think very large pulse widths will be the right ones. 500, 600, 1,000 microseconds. We're looking at less than 500, but that's still a point of debate. And polarity is still a point of debate. Amplitude is being done primarily by side effects. So how much can the patient tolerate and staying below a side effect threshold? But the ideal amplitude is not yet known for this target. And this could be one of the reasons why you see variance, some patients doing better, some patients doing worse. It's perfectly possible that because we are in the early phases of investigation, that we simply did not come up with the best programming settings for the patients that did not respond, and we found better settings for the ones that responded really well. And presuming, and I want to highlight this, presuming that there will be standard settings like we have in DBS for Parkinson's disease, I think is a dangerous proposition. And that's why we're looking for a biomarker with so much engineering into it. Essential tremor is a very prototypical disease. Patients look more or less alike. Parkinson's disease is quite variable, but tremor from Parkinson's disease, very similar across patients. You turn it on at 130 hertz, 90 microseconds of pulse width, you get your polarity, monopolar or bipolar, in the dorsolateral territory of the STN, it's going to get better. Strokes are very heterogeneous. Even carotid or middle cerebral artery strokes vary a lot. Large, small, more internal capsule, less internal capsule. I don't believe that this line of research, that this line of investigation will identify one setting that will be universal for patients. I think we're going to need to continue to work on a biomarker and rely on a biomarker to guide which settings to pick for each individual patient.
Great.
I don't know who asked the question. It's an incredibly insightful question because yes. I skipped it. I didn't present how programming was done. And it is a very deep part. I have about 150, 200 slides worth of programming information. And what is it that we're learning? What are the effects of programming on EEG, on the electrode itself, as well as on transcranial magnetic stimulation? It's still quite evolving.
Thank you very much.
Very smart question.
Hey,
I would like to say thank you, everybody, and the audience, the moderators, Professor Machado. It was brilliant. Again, thank you for your time. And I would like to call Professor Almeida to closing remarks. Professor Almeida.
Andrea, first of all, I would like to thank you very, very much for your presentation. It was great to see you again. You are looking very well. It's good. Not hair, but it's not a problem at all. So I would like to thank everybody staying here and the audience. That's the reason why we are doing this series of webinars. And the next week we'll have another session. So thank you all. Bye.
Bye-bye. Best wishes and take care.
Bye. See you later. As soon as possible.
Bye.
As soon as possible.
Muito bom, André.
Bye.
Obrigado, tchau, tchau. Bom ver vocês.
Tchau, obrigado.
Obrigado.